start the second session. Co-chairing Dr. Anna Ben-Abed, Professor of Neurology at Wayne State University in Detroit. I'm Hassan Hassan, Professor of Neurology. I have the pleasure to introduce Dr. Luigi Stravi. He's a professor of neurology. So both of us have neurology. The rest of the audience, no neurologists except myself. Neurology. Okay. So how many neurologists? They're all three physicians. Professor Stravi is the president of the World Sleep Association. I'd like you to tell us something about the World Sleep Association. I don't know, Dr. Shahira, do you have a chapter here of the sleep?
Africa. One representative of Africa. And we want two representatives, one North Africa and one South Africa.
And how many members do you have in this society?
3. Sorry. Slovenia, then. So by the time Dr. Stravi leaves, we should have 100.
This is a project. But not just for me, for the increasing awareness for sleep medicine. I think it's very important. If you follow the first session, sleep is very important. Okay, thank you very much for inviting me. I'm very glad to be here. And you can see I made a little changes in the title of my talk, because I included in the brackets cognitive function. Why I include the cognitive function in the bracket? Because I think that. Okay, so now it's better. Oh, okay. So I said that I made a little change in the title of my presentation, that I put cognitive function in the brackets, and I will explain you why. Because I think that we cannot talk about the neuroimaging without reference to the cognitive function. They are very, very related, and I will explain you why. So, first point is that you can see two of my patients, and I would like to say that osteoarthritis Liperna is not just sleepiness. And I hope that I will convince you at the end of my presentation. And you can see also, this is the first paper published in 1985 by Case and co-workers that showed that in majority of osteoarthritis Liperna patients who have a cognitive impairment. And you can see in 1985, so this means that cognitive impairment in this kind of disease is very important. And you can see the last paper published in this topic, and you can see that in osteoarthritis Liperna patients you have the impairment of several domains of cognition. Wow, I said neuroimaging and cognitive function, because neuroimaging studies in the last years helped us in understanding the profile of cognitive impairment in osteoarthritis Liperna, and also help us for explaining the physiological and pathological condition in several disorders, sleep disorders, including sleep apnea. How can we study brain abnormalities by neuroimaging techniques? You can see we have different possibilities. We have we can see structural brain changes, and we can see this kind of changes by VBM, diffusion tensor imaging, DTI. We can study the functional brain changes, and you can use SPECT, PET, and functional MRI. And you can see also the evaluation of chemical brain changes by AMA spectroscopy. So unfortunately, I have not time to explain all of these different techniques, but I mentioned some data in some of these different methodologies. We will start with VBM, voxel-based morphometry. This kind of examination is very important for the evaluation of gray matter in the brain. And VBM has become increasingly widely used for examining brain changes in healthy aging or neurodegenerative disease. And this very important technique, and I would like to show you why this technique is important. I think that this paper is very crucial paper that shows very clearly that the VBM is important for the evaluation of the function of the brain. The authors, my friends from Cracovia, evaluated the structural MRI of the brains of taxi drivers in London. And they found that taxi drivers show a posterior hippocampus significantly larger compared to the normal controls. So this means that if you use for your job, in the case of taxi driver, you use a lot the posterior hippocampus that is very important for the navigation, for the spatial experience. You have an increase of this structure. We have a lot of studies for VBM in status determinant patient, and you can see some of these studies, and I will show you very briefly. The first paper was published in 2003 by the group of Morel, and they show that there is a change in brain morphology in different areas. And another study by Torelli that showed significant changes of brain matter volume in right hippocampus in status determinant patient. This is another paper by Bongong, by Korean group, that showed that gray matter concentration was significantly decreased in Osa patient in several areas, including left gyrus rectus. You can see bilateral superior frontal gyrus, right insular gyrus, bilateral thalamus, but again, bilateral hippocampus. So this means that hippocampus is the structure much more involved in status determinant patient. This is another important study by the same group from Korea, and you can see that the authors show that there is a localized cortical feeling in patients with a status determinant patient. You can see the difference. You can see the normal controls, and you can see the status determinant patient, and you can see the difference. But this feeling is localized. You can see in some areas, especially in the blue areas, you can see with different methodology. In a status determinant patient, you have the feeling of cortex in specific areas. I would like to recommend you to read this paper because it's a very important paper that shows that the gray matter reduction, the authors consider the articles published between January 2000 and February 2012, and you can see that in this study, clearly the authors show that there is a regional gray matter reduction, but especially in bilateral parahippocampus, and less convincing data we have for right superior frontal and left temporal in patients with sleep apnea. But again, hippocampus and parahippocampus are the areas much more involved in status determinant patient concerning the gray matter. However, you can see that there are some discrepancies between VBM studies in OSA patients. Why? Probably this is due to statistical threshold differences and the development of imaging software over the years. So this means if you use different technologies, you can find different areas involving the status determinant. Moreover, there is another important question. Those treatment reverse structural brain changes in status determinant patient and improve cognitive function. This is a not trivial question. The problem when you use a CPAP, I would like to remember that there is some problems in terms of duration of treatment, because we know very well that, for instance, if you use for a very short period CPAP, you cannot see a very important improvement in terms of cognitive function. So this is the first problem that we have with the evaluation of CPAP treatment on cognitive function. The other problem is just already mentioned in the first talk by Professor Bhatt, the problem of the every night use of CPAP. And we know that we can see normalization of memory abilities in 21% of poor users, means less than 2 hours per night. 44% of moderate users, between 2 to 6 hours, and 68% of optimal users. This means more than 6 hours. So this is a very important point, because when you evaluate the effects of CPAP on cognitive function, and we see also in the neuroimaging studies, it's very important to consider the number of hours of use of CPAP every night. So I would like to show you the data that we published 2 years ago in American Journal of Respiratory Critical Care Medicine, we studied patients with very severe sleep apnea, and we consider the VBM results in this subject. And also, I would like to present also the data after 1 year of treatment, because actually we have also the data after 1 year. You can see the exclusion criteria, and we can see which kind of evaluation we perform: full polysomnography, neurocognitive function, sleepiness, and so on. And you can see the data. You see the sleep apnea index, and you can see after 3 months and 12 months of treatment, you can see the mean SL2 saturation, and you can see very, very severe patients. What about the results? We found after in the baseline condition, a significant gray matter volume reduction in our obstructive sleep apnea patient. And you can see the different areas in which find this kind of reduction. And another important thing is that we found a significant correlation between the gray matter volume reduction and cognitive performance, exactly according to the different tests that we use for the cognitive evaluation. Especially executive function and sleepiness was involved in our patient. So we found a neuropsychological impairments in association with focal gray matter volume reduction in the left hippocampal and torinal cortex. We know that it's very important, it's a crucial region for memory. In the left posterior parietal cortex, associated with attention, and in the right superior frontal gyrus, that is a part of executive function network. What happens after 3 months? You can see that after 3 months we found a significant gray matter volume increase, and at the same time we found an increase in amelioration and an improvement of cognitive function. Especially, you can see for executive function. What happened after 1 year? After 1 year, no region showing a significant gray matter volume increase when using a statistical threshold corrected for multiple comparison. So this means after 3 months, you can see a change in gray matter volume, you can see a change in cognitive function and an improvement of cognitive function, but after 1 year, no further improvement. This is our data, but we have other data by the Korean group that they found after 6 months of CPAP exactly the same data that we found after 3 months. And the problem now is that what is the mechanism of brain damage? Is it neurogenic? Is it vasogenic? And other point is that what is the potential contributors of cognitive impairment and neuroimaging changes? What is much more important, hypoxemia or sleep fragmentation? It's very, very, very crucial question. Concerning sleep fragmentation, we have a data in insomnia patient. We know that in insomnia patient, there is a relationship between hippocampal volume and the duration of insomnia. So this means that you have a progressive decrease of hippocampal volume with increasing of duration of insomnia. But the same thing is true for the sleep fragmentation. There is a correlation between the hippocampal volume and the arousal index. But we can say that it's similar things we can find in sleep apnea patient. We don't know. We don't know, but we know that this is a very important study by Jaff and co-workers that showed with a prospective study in women, very old women, that there was a relationship between a sleep apnea at baseline and the development of MCI, mild cognitive impairment, and dementia. And in this paper, the authors clearly showed that the relation was strictly related to the oxygen desaturation, much more important than for sleep fragmentation. I think that is a very important point. It's an important point, and I trust that it's a very important point because I wrote the editorial in JAMA concerning this paper, and they said that no medication are actually known to prevent the progression of mild cognitive impairment to Alzheimer's disease. So treating at-risk patient with CPAP for sleep disorder breathing may be a prevention strategy. I think that is a very important point. And again, we listen that it's important sleep apnea for cardiovascular consequences and so on, but I think that is another important point, It's also important for the treatment of this patient, for the prevention of cognitive dysfunction. So this means that it's very important to make an early diagnosis and treatment of this patient. And another point is that when we have to consider this patient from the cognitive point of view, we don't need, this is the battery that we use for our patient. We don't need all of these tests, But our study showed that DigiSpan, Corsi, and Stroop tests are sufficient for the evaluation of this patient and the follow-up of this patient after the treatment. So after VBM, some data on DTI. DTI allows to characterize microstructural changes of white matter. And this is the first study that showed that DTI is important in osteoarthritis sleep apnea patient. In this paper, the authors showed that there was a bilateral white matter involvement in osteoarthritis sleep patient, but unfortunately in this paper there are no data on treatment. The same author also showed that there was a mean diffusivity decrease in osteoarthritis sleep apnea patient with the same techniques, DTI, and we made the investigation of DTI in our severe patient compared to healthy controls, and we evaluated changes after 3 and 12 months. You can see I cannot enter in the details, because I know that the majority of you are pulmonologists, I'm not neurologists, I'm not poor neurologists like me, so I cannot explain in details all of these things, but you can see that there was a significant fractional anisotropy reduction in osteoarthritis sleep apnea patient in multiple areas, in right and left hemisphere. What happens after 3 months of treatment? No changes. No changes. What happens after 1 year? All abnormal areas at pretreatment showed a significant decrease of extension after treatment with CPAP. And cluster of pathological boxes were located in the same areas found at pretreatment time, but were significantly smaller. So this means with CPAP, you can change the DTAA abnormalities in the white matter. You can see the results after 1 year, complete recovery in all of this area, uncinated frontal occipital fasciculus, fornix, and you can see the significant recovery in the left partial, in the right almost complete for the longitudinal superior fasciculus left and right after 1 year. Was the same for the mean diffusivity, also mean diffusivity, the decrease at baseline condition and the increase in osteoarthritis sleep apnea patient after 12 months of treatment. And so, our study showed that there was a significant FA and MD differences in the brain of osteoarthritis sleep apnea patient before treatment. But the white matter abnormalities changed completely after 12 months of treatment. So we see that there was an increase in FA and MD, and this means that the damage was not permanent. But which kind of problem we have? The problem of interpretation of data. Why? We can say, okay, there is this kind of alteration, changes in white matter. Cerebral perfusion is chronically uncorrected in osteoarthritis sleep apnea, and we know that this could create a potential for ischemic damage, particularly at the level of the small valves. And recent studies show that DTI changes related to small vessel diseases largely correspond to axonal changes rather than gliosis. We hypothesize that an axonal sufferance from a mild ischemic injury causes reversible injury, reflected as the decrease on fractional anisotropy and mean diffusivity. The problem was how we can explain the different results we obtained after CPAP treatment, because this was a problem. Because in concerning gray matter volume, we observed after 3 months of treatment changes, important significant changes, with no further structural changes after 12 months. With DTI, we found exactly the reverse. So probably this means that white matter of the brain takes longer to respond to treatment than the gray matter does. But we don't know exactly what is the relationship in terms of the function of CPAP in these changes. This is the study that I think that is very important concerning DTI, because we use DTI for osteoarthritis sleep apnea patient. But I would like just to remember concerning DTI that there is a very interesting study that showed that there is a microstructural cerebral damage in the white matter of patients with central sleep apnea. I think that this paper is very important because in this paper the author showed that there is a microstructural changes in the brain state that can be measured by DTI, by these techniques, and not with the conventional, traditional techniques. Very few words for the functional MRI. With the functional MRI, we know that when we consider the patient with these techniques, we know that there is an over-recruitment of some brain regions on verbal learning tasks in obstructive sleep apnea patient. This is an important point. And probably this recruitment of additional brain regions to participate in verbal learning performance in obstructive sleep apnea patient likely represented an adaptive compensatory recruitment response. It's an important point. So this means that you have sleepiness, you have problem of attention, and to compensate this kind of deficit that you have, you recruit more brain regions to follow your verbal learning. Concerning working memory has been demonstrated to be impaired in obstructive sleep apnea patient, and we know that there is this test, the LVAC, that is a classic test for working memory used in the functional MRI study. This is the first study that showed that there was a decreased activation in dorsolateral prefrontal cortex during working memory in obstructive sleep apnea patient. And partial recovery has been demonstrated after treatment in this patient, partially recovered. And we performed this study that we published some years ago in Sleep. And we investigate the possible cerebral activity changes between obstructive sleep apnea patient and healthy controls, using by 2 bags working memory test. This is the inclusion and the exclusion criteria. Obviously, we excluded patients with dementia. And you can see the neuropsychological results. We found a significant impairment of cognitive function in baseline obstructive sleep apnea patient compared to early controls. And we found a significant improvement after 3 months of treatment with CPAP. What about the behavioral results during scanning, during the functional MRI? This is very important because we found no significant difference in this test between obstructive sleep apnea patient and controls. And the most important thing is that when we consider the direct comparison between sleep apnea and controls, we found a stronger activation in obstructive sleep apnea patient in several areas, especially in the areas involving the attention, left inferior, middle, and superior frontal gyri, medial precuneus, left putamen, frontopolar cortex. And again, stronger activation in controls in left middle occipital gyrus, right middle orbital gyrus, and caudal pons in the brainstem. So this means that obstructive sleep apnea patient compared to controls have an increased activation of the areas involved in the attention test. What happens after the treatment? With the treatment, we found that this activation was reduced after treatment. So CPAP may normalize this increase of activation of these areas involving the attention after treatment. In obstructive sleep apnea patient, normal levels of performance on working memory tests is associated with the recruitment of additional areas, in particular left prefrontal regions. And it's very interesting because similar compensatory mechanisms have been reported in normal aging, as well as in patients with MCI and Alzheimer's disease in the early stages. This compensatory additional recruitment was reduced after CPAP, and this change may reflect the improvement in several neuropsychological measures that we observe after treatment. This is a very new study by my friend David Gozal, that showed that in young subjects, in children with obstructive sleep apnea patient, you can see exactly the same. In these children with obstructive sleep apnea patient, we have a greater neural recruitment of regions implicated in cognitive control. So again, this means that in these children, you have an increase of this activation, and probably this could be related to the hyperactivity that you can observe in children with sleep apnea. So I hope that I convinced you that obstructive sleep apnea patient is not just sleepless. And however, I would like to remember that it's not so easy to perform this kind of study. Because when you perform neuroimaging study and neuroimaging plus cognitive function studies, you have to consider the sample size. You have also to consider the effect of, for instance, mild obstructive sleep apnea patient. We don't have data in this kind of population. We don't have data in upper airway resistant syndrome subjects. It could be very important because usually the studies have been performed in severe obstructive sleep apnea patients. But it could be very important to evaluate also this patient in the early stages of the disease. Another important aspect is the influence of body mass index, the influence of excessive daytime sleepiness, the problem of comorbid conditions. And also, we would like to know exactly what happens not just with CPAP, but for instance, with other possible alternative treatments. And at the end, I would like to thank you for your attention. Thank you.
I'd like to thank you very much, first of all, for the very
I know there's a discussion is at the end, but if
I think it's better to perform discussion much after the Thank you very much. And now I'd like to present Professor Dr. Tarek Asad, he's the head of the Sleep Center in Ain Shams University, and Professor of Psychiatry or Neuropsychiatry in Ain Shams University. Professor Dr. Tarek Asad is a very well-known he presents neuropsychiatric manifestations of sleep.
Thank you, Professor Ed, for the introduction. Thanks, Dr. Shahira, for the organization. Actually, it's very hard to talk after Professor Luigi, and part of my talk will tackle his point about cognitive dysfunction in obstructive sleep apnea patients. Really, I am basically a psychiatrist, but I am interested in sleep medicine. So, when I practice psychiatry, I feel homesickness to sleep. And when I practice sleep, I feel homesickness to psychiatry. That's why the choice of my presentation was about the interface between psychiatry and one of the main disorders of sleep, which is obstructive sleep apnea syndrome. Actually, to my mind, obstructive sleep apnea is not just a mere sleep disorder. It's far behind this. It's invasive to all the specialties. It's very hard to find any specialty in which sleep apnea has a print, a fingerprint on it. Pediatric, neuropsychiatry, chest, any specialty. Of course, I'm not going to talk about the overt presentation of the sleep apnea, but I'm just emphasizing the covert presentations. And I stress upon one aspect of these covert presentations, that's the psychiatric presentation. I leave the neurological presentations to my colleague, Professor Jaidak. She'll talk about Parkinsonism, neurodegenerative, and strokes, but I just stressed about the psychiatric covert presentations of sleep apnea. Of course, let me summarize what are the psychiatric symptoms which could be encountered in patients with sleep apnea. First, and of course most importantly, is the secondary sleep disorders. If you take daytime sleepiness, it's a cardinal feature for sleep apnea. It's very hard to find a patient with sleep apnea without this daytime sleepiness. It explains most of the hazards like accident proneness, occupational malachievement in sleep apnea syndrome patients. But in sleep apnea, you can find what we call secondary parasomnias. You can find a patient who exhibits sleepwalking syndrome. It's due to sleep apnea, or sleep talking, or confusion arousal, or the recently described sleep drunkenness, or sleep paralysis. All these parasomnias can be traced in obstructive sleep apnea patients. Of course, the complaint of insomnia is not that common in obstructive sleep apnea, but some patients have this complaint. Regarding depression, the studies range from up to 10 up to 46.1 in some studies. Of course, if you consider depressive disorder, the prevalence is less. If you consider depressive symptoms, of course, you can find even more than 46. What's the mechanism of depression in patients with obstructive sleep apnea? why do obstructive sleep apnea patients have more depression than the general population? This could be attributed to psychological factors, adjustment reaction to the handicap caused by obstructive sleep apnea, or it could be related to the circadian rhythm disruption induced by the sleep fragmentation, or it could be explained by the immune and inflammatory factors. And now in psychiatry, there is an ongoing theory making so much interest studies, what's called the immune or inflammatory theory of depression. Of course, you can explain depression as due to immune dysfunction, and immune dysfunction is quite a common complication of obstructive sleep apnea. Could be related also to neuroendocrine factors. What differs in the depression associated with obstructive sleep apnea than the other depression? You know, depression usually present with insomnia and anorexia, but in obstructive sleep apnea patients, you can find atypical features. Although the patient is depressed, but he is hyperphagic. Although the patient is depressed, but he is hypersomnic. Actually, some of those patients have multiple somatic complaints. So they tend to present with what we call masked depression rather than the clear-cut depressive symptoms. Of course, the presence of depression will add to the insight of the sleep apnea. So we are expecting with depression more impairment in functioning and more impairment in the quality of life. The recent reports show that even the depressive symptoms can respond to the CPAP treatment, and here there is a problem, which antidepressant to use. If you give, for example, antidepressant which will produce sedation, it will aggravate the sleepiness. So SSRIs, especially the activating SSRIs and SNRIs, are of choice here. Some of the dual action drugs, like for example the bupropion, which is norepinephrine and dopamine reuptake inhibitor, might be of help, even not to the depressive symptoms, but for the sleepiness. Of course, one of the approved drugs in sleep apnea, which is modafinil, it might have some antidepressant or add to the antidepressant effect. Regarding anxiety, the reports of anxiety even exceeds those of depression, according to some data. We can find generalized anxiety, we can find panic, we can find post-traumatic stress disorder, but interestingly, you can find phobic anxiety. And imagine a patient with claustrophobia. He has obstructive sleep apnea. How can he use the CPAP? It is very difficult for a patient with claustrophobia to use a CPAP. So sometimes the anxiety is a hindering factor in the treatment of sleep apnea, especially if the patient has some sort of phobic disorder. Substance abuse, Batson et al. Found no correlation between obstructive sleep apnea and substance abuse. But in a recent study I'm about to finish within 2 months, I found the prevalence of substance abuse is high, 17%. And what was astonishing me, the most commonly used drug is tramadol. Tramadol is not only an opiate drug, but it acts as SNRI. So it increases the level of noradrenaline and increases the level of serotonin. Because it increases the level of noradrenaline, it is an activating drug rather than narcotic. That's why it's widely used by the drivers. And I remember one of the misfortunes which happened to me 7 months before. I was giving a lecture in Alexandria about the safe driving. And the limousine driver, which took me back to Cairo, was taking tramadol. And he fell asleep while we were driving, and it was a terrible accident. Fortunately enough, I'm alive. But when I asked him why you are taking this, he said, I want to make more money. So tramadol makes me more alert. But what about the effect of caffeine on sleep apnea? Whether it is good or bad? Some studies found that the caffeinated soda preparations may increase the severity of apnea. But other studies about the use of simple tea or coffee said that they might have a beneficial effect improving cognition. So, controversy about this. Of course, the effect of alcohol might aggravate the complications of sleep apnea. Regarding cognitive function, I am very thankful for Professor Luigi, because actually I presented an abstract to the next Wassam in Seoul about the executive function in obstructive sleep apnea patient versus patients with primary insomnia. My research question was, cognitive dysfunction, especially executive dysfunction in sleep apnea, whether it is related to sleep fragmentation or it is related to the hypoxemia and the other pathophysiology in sleep apnea. So what came to my mind, why not to compare obstructive sleep apnea, in which there is multiple pathophysiologic factors, with patients, primary insomnia patients, in whom the only pathophysiology is fragmented sleep. And I applied a lot of neuropsychological tests, trail making, Wisconsin curve sorting, digital sample substitution. According to my result, I found a significant difference between patients with obstructive sleep apnea than patients with primary insomnia, which means that, according to my result, the sleep apnea patients, the neurocognitive dysfunction is more related to the hypoxemia and maybe the other pathophysiologic factors, not only the mere sleep. Of course, if I listened to your presentation, I should have changed my mind about sending it. The mechanism of neurocognitive dysfunction is not only related to the impaired attention and vigilance, because you can find other executive dysfunction in which attention is not only the main dysfunction. It might be related to chronic hypoxemia, secondary vascular insight. Of course, a lot of multiple pathophysiology can explain the neurocognitive dysfunction in patients with obstructive sleep apnea. Male sexual dysfunction is a major complaint in patients with sleep apnea. It includes not only erectile dysfunction but decreased libido, and this can be explained not only by psychological factors like depression, but neuroendocrine factors, and actually the level of the male hormones in some patients is less than control. Of course, this will have its impact on the marital dysfunction, and it will add more to the depression and to the impairment in quality of life. Eating disorders, of course, there's a strong relation, mutual relation between eating disorders and sleep, between obesity and sleep. These are the neuromodulators, and Professor Badr mentioned a lot about the leptin and ghrelin, how this is dysfunction in sleep-deprived patients. And if you can summarize how can disorder sleep lead to obesity, this is the sleep disorder and this is the mechanism behind. Sleep deprivation will increase ghrelin and decrease leptin. Sleep-related eating disorder, high-caloric food intake during sleepwalking. And obstructive sleep apnea, there is decreased sleep efficiency, will have the same effect like sleep deprivation. And we might have REM, sleep behavioral disorder, which is a part of a dream. And we have the night eating syndrome, which is night binge eating. Of course, several studies found the level of leptin and ghrelin are disturbed in patients with obstructive sleep apnea. But what can add to this is the increased cortisol, which make more craving for high-fat, high-carbohydrate, what we call the comfort food, to increase the serotonin and alleviate stress. For those who are not sleep specialists, I'll just mention what is sleep-related eating disorder. Sleep-related eating disorder is a condition in which maybe a female, I think it's more in females, the female awakens by night, she walks, she went to the fridge, she opens the fridge and selects carbohydrates or sweets, and then back to bed, and in the morning she is not remembering, but stab it all. And actually the maid is accused, the husband is accused, the children are accused. It's accidentally discovered when you find some food on a white sleeping dress. This chocolate came from where? Actually, the importance of this syndrome is that it is gaining much increase in prevalence, and one of the studies found that a good percentage of those visiting obesity treatment clinics, they have this syndrome, which is sleep-related eating disorder. Unfortunately, some of the sleeping pills might induce this condition. We have to differentiate this syndrome from what we call night eating syndrome. In night eating syndrome, which is induced by some of the psychotropic, the patient gets awake by night. He's awake, he's fully awake. He's not in a state of sleep. And he has craving for food. The last I want to mention about the psychiatric complication of sleep apnea is personality change. It's very common. You can find features of irritability, nervousness, lack of motivation, lack of interest. This might be an exacerbation of already present trait, but it could be related to chronic hypoxemia. Some of the patients say that this was not my personality before I'm obese, before I have this obstructive sleep apnea. Let me just, I want to express some of the results in my study. I'm about to finish in 2 months. Just I'm giving the prevalence of the disorders I found. Sleep disorder in my sample, 92. Mood disorder, depressive symptoms, 35. Anxiety disorders or symptoms, 31. Cognitive dysfunction, I applied here the executive function tests and the neuropsychological assessment, so it's a little bit high, 28. Eating disorder, 7%. Substance abuse, especially tramadol, 17%. Sexual dysfunction, very high, 37%. Personality change, 14%. What about children? What are the psychiatric complications for a child who has sleep apnea? You are expecting more ADHD. Some studies found that there is 20%, 20 to 30% increase in the prevalence of attention deficit hyperactivity disorder with patients with sleep apnea. Together with my colleagues in Insham's pediatric department, we made a thesis about the sleep polysomnography profile of 30 children with nocturnal enuresis. 4 of those children were found to have sleep apnea. So sleep apnea could be one of the factors behind nocturnal enuresis. Of course, intellectual impairment, conduct disorder, and secondary parasomnia. Let me just give some of the updates about management of obstructive sleep apnea, just to refresh your, as a form of brainstorming. The following drugs are FDA approved for use in obstructive sleep apnea. Zolpidem is a Z-hypnotic. Ramiltion is a hypnotic which acts on melatonin. And by the way, you know what is the most recently approved hypnotic? It doesn't act on GABA, it doesn't act on benzodiazepine receptors, it doesn't act on melatonin. For the first time in August 2014, the FDA approved the first drug which acts on orexin, the first orexin antagonist, Bilsomra, which is approved by the FDA for treatment of insomnia. Modafinil, which is the standard treatment of narcolepsy, armodafinil, all of the above, none of the above. Of course, these modafinil and armodafinil are approved for treatment of sleepiness in 3 conditions: narcolepsy, sleep apnea, and shift worker syndrome. So you can use modafinil just not to treat the sleep apnea, of course, but to improve the sleepiness. The following devices are FDA approved for management of obstructive sleep apnea: CPAP, BiPAP, EPAP. Of course, you know the EPAP. I think neurologists, neuropsychiatrists don't know what is the EPAP. It's the expiratory. Yeah, it's a single-use device. It's applied to the nose. It's like a valve. Air will pass during inspiration, as it is, but during expiration, it will pass into the valve pieces. So this will increase the pressure. All of the above? Yes, it's all of the above. But what is the most recently FDA-approved treatment of obstructive sleep apnea? Is it BiPAP or adaptive servo-ventilator? You know the adaptive servo-ventilator? Yeah, of course, the pulmonologists, they know what's the adaptive servo-ventilator, but this is the most recently approved treatment. It is the Inspire implant device or the pulse generator. It's approved in May 2014. What is the idea of this device? It's an implant like pacemaker. It's to be put to stimulate the hypoglossal nerve. It is very sensitive to the effort of breathing. If I'm having an labored breathing, the sensor will act. It will stimulate the hypoglossal nerve. The hypoglossal nerve will prevent the retraction of the tongue and will prevent the apnea. Of course, it's fascinating for me, but I don't know whether in practice it works or not, really. Some of the news updates about what's new, breaking news about sleep apnea in October, November 2014. Sleep apnea here doesn't squelch sexual life. You know the very interesting picture of the 2 couples wearing CPAP? Yeah. What was found in this study, which presented in the annual meeting of the American College of Chest Physicians, in Austin, they found that the treatment of sleep apnea doesn't impair sexual life. So you can practice sex with this CPAP. I don't know why. I don't know how. Sleep apnea may steal some of your memory. This an article presented in the Journal of Neuroscience. It's true affection of the spatial memory, affection of REM. And you know, who is the winner of Nobel Prize in Medicine this year? You know? The winner of Nobel Prize, physiologists. They discovered what is in our brain. It's the internal GPS. Three physiologists discovered. Place cells found in the hippocampus and the grid cells found in the entorhinal cortex. In our brain, there is a GPS which controls the navigation system. It's a very complicated cognitive task. The most complicated task in nature is how to compute this navigation system. Obstructive sleep apnea may decrease depressive symptoms, and this presented in the PLOS journal maybe 10 days ago. Thank you very much.
Thank you very much, Professor Dr. Starr. This very nice lecture. And I remind you that the questions will be by the end of the session. Our next speaker. Let me welcome Dr. Loza-002. She's a lecturer in neuropsychiatry at Alex University. She's going to present sleep and neurodegenerative disease. Thank you.
First, thank you very much for the introduction and thank you for the invitation, Dr. Loza. It is a real honor to present in front of professors for whom I read papers actually. It's very embarrassing. After 2 great lectures, it's a challenge to see anything which may add to your knowledge. And when I was invited, Dr. Loza asked me to tell me to speak about something about our experience in the Alexandria University lab, in the neuropsychiatry department. So we chose the topic of neurodegenerative disorders. For some of you who are not neurologists or psychiatrists, there is a difference between apoptosis and degeneration. Eventually, both will run into the pathway of neurodegenerative disorders. When we have apoptosis, it's a matter of programmed cell death through certain cells or certain regions in the brain, causing the degenerative disease. Classically speaking, like Parkinson's disease, Alzheimer's dementia, cerebellar ataxia. And we have degenerative disorders that might start as another pathology and then fade into a degenerative pathway. Like, for example, multiple sclerosis, by definition, it's demyelinating disorder, but the end result at the late stages is a degenerative disorder. The same for stroke. Stroke is a vascular disorder, and the last pathway is usually the degenerative one. The big classification for neurodegenerative disorders are usually clinically subdivided as neurodegenerative disorders causing movement disorders, causing dementia, trinucleotide repeats like Huntington's disease, diseases causing weakness or atrophy like amyotrophic lateral sclerosis or the family of motor neuron disease, hereditary ataxia, and hereditary neuropathy. The neurodegenerative disorders related to movement disorders or dementias are the most popular studies for sleep disorders. Those were the first diseases to be screened for sleep disorders in the field of neurology. We have been, in the past 11 years in our experience, limited experience actually, we had studies, add to all the patients who come for a sleep study. We have structured studies on dementia, Parkinson's disease, cerebrovascular stroke, epilepsy, multiple sclerosis, and stage renal disease and schizophrenia. Those were, in order, the most popular cases which we had studied, sleep studies, studying their sleep disorders. My topic, I will talk about briefly about our limited experience in Parkinson's disease and cerebrovascular stroke. Parkinson's disease is the class of the most important extrapyramidal syndrome with the most important diagnostic criteria of tremors, bradykinesia, and rigidity. These are the chief motor manifestations of Parkinson's disease. And on, we have non-motor manifestations. The most important non-motor or most popular or prevalent non-motor manifestations is sleep disorders. More than 79% in other studies, about 90% of the Parkinson's disease suffer from one sort of sleep disorder. Most of them require treatment because their sleep disorders affect the course of the disease itself and the prognosis of these patients. We had a limited study of 36 patients who had Parkinson's disease, idiopathic Parkinson's disease by definition by the UK Bank criteria. The causes of sleep disorders in a Parkinsonian patient might be related pathological changes like impaired sleep-wake cycle, circadian rhythm disorders, or sundowning. Impaired sleep architecture, the change between REM and non-REM sleep, and impaired arousal system. The nocturnal motor symptoms are the most disabling for the Parkinsonian patients, especially that they are both related to the disease itself and to the treatment. Wearing of phenomena, rigidity, akinesia, tremors, restless leg syndrome, and dystonias occur during the night, interrupting the patient's sleep. Other nocturnal non-motor manifestations like depression, psychosis, and anxiety, cognitive impairment might also contribute to worsening of the quality of sleep of the patient. Sensory manifestations of Parkinson, hallucinations and nightmares, especially the vivid dreams, are very frequent complaints of our patients. Some of the medications used to improve Parkinsonism worsen the course of the sleep disorders, for example, like the dopamine agonists and D1 and D2 receptor agonists. Comorbid primary sleep disorder might also alter the course of Parkinsonian patients. The REM behavioral disorder, a famous phenomenon that might precede the Parkinsonian manifestations by years, 10 to 20 years, even before the onset of the classic manifestation at the age of 40 or 50. The most common result we found was insomnia. This is the hypnogram of one of our patients, where he had very long periods of awakening during the night. His sleep efficiency dropped to the 70%. The restless leg syndrome, when we compared the patient, this is one of our studies with the restless leg syndrome manifestation. There was a significant difference between the patients and the non-Parkinsonian patients. We had a study with a control group of non-Parkinsonian patients. We used the Parkinsonian sleep scale to evaluate them and overnight polysomnography. This is the Parkinsonian disease sleep scale, which is very sensitive, 15 diameters, giving marks. The smaller the score, the worse the sleep. So when comparing patients and non-patients, we found that the patients with Parkinsonism had a worse score or a lower score on the Parkinson sleep scale. Their polysomnographic data showed significant difference in the duration of slow wave sleep. It was markedly less in the Parkinsonian patients. They had a very large number of change of position during sleep, and their limb movement index was significantly higher. This, for example, was the duration. This is a little bit late, so we have stage 3 and 4. Now we can use them. In the sleep indices, the limb movement index was more than 4 times higher than the control group. The number of change of position also during the night was very high. The respiratory disturbance index, it was not such a significant difference in these patients. This is, for example, one of the control patients with a few movements or change of position in bed, while this is one of the Parkinsonian patients. He's rolling all the night in his bed. And this is also different in the diagrams between the periodic limb movements in the patient and in one of the control persons. The dopamine agonists showed a worsening of the limb movement index. So we use them usually to improve the limb movement disorder. Thus, the result in our study was that it was even worse for those patients, leading to more fragmentation of sleep. The respiratory events were higher among the Parkinsonian patients related to the autonomic changes and even rigidity in the respiratory muscles, but it was not such a huge difference between patients and control. This was for Parkinsonism. As for cerebrovascular strokes, which I'm really interested in what you said before in the 2 lectures, because I will touch some of these topics now. In the obstructive sleep apnea, mainly as one of the established risk factors for cerebrovascular stroke or cerebrovascular insults, we have the hypoxemia, the reoxygenation, the hypercapnia, and then changes in intrathoracic pressure. These changes in the intrathoracic pressure should also have an impact on the carotid vessels. Those patients with marked sleep apnea had more atherosclerosis in their carotid vessels. When we have this intermittent hypoxemia and intermittent blood flow and change in the cerebral perfusion, we have activated vasoconstriction, increase in the catecholamines, tachycardia, endothelial dysfunction, oxidative stress, which is triggered inflammation, and increased coagulation. This is the very rich medium to have stroke, and it's usually a vicious circle. If a patient with cerebrovascular, with obstructive sleep apnea, has a vascular insult, whether cerebral or cardiac, usually he will develop another one. We had 93 stroke patients. We assessed them twice, immediately post-stroke and 1 month later. comparing their NIHSS scale for the Parkinson, for stroke, and the Epworth Sleepiness Scale and Pittsburgh Sleep Quality Index Scale, and comparing both results together. As for the sleep quality, it was way worse in the patients. It was way worse post-stroke. We took the history from the patients before stroke and after stroke. Post-stroke, we had a worse sleep quality. We had excessive daytime sleepiness. There is a positive correlation between the severity of the stroke itself and excessive daytime sleepiness, the Epworth Sleepiness Scale. There was a positive correlation between both. Correlating between the NIHSS scale and the Pittsburgh sleep quality, it was also a positive correlation. Thus, even after 1 month comparing the outcome, the neurological outcome, compared to the quality of sleep, the worse the outcome, the worse the sleep. The polysomnographic data showed that our stroke patients had shorter durations of sleep. The total sleep time was less than normal. Comparing both of them as regard the sleep efficiency, it was also worse in stroke patients. Comparing both of them at the sleep stage per hour of sleep, it was higher in our patients. Thus, the sleep architecture was markedly disturbed in stroke patients. Comparing the sleep stages, there was no significant change between both groups, except for REM sleep, which was a little bit higher and out under the control. It was shorter in stroke patients. The REM latency was also longer in the non-stroke patients, or shorter in stroke patients. Comparing the stages, the hypnogram between both cases, you can see the differences, the change between the stages, the duration of REM sleep, which is shorter in stroke patients and longer here in the control group. The deep sleep is here still shorter than the normal control persons, but not significantly different. In the sleep increases, the arousal index was significantly higher in the patients. They used to wake up at the night more frequent than non-stroke patients. The limb movement index was also high. As you can see, the number of arousals in a control person and the number of arousals here in the stroke patient. The periodic limb movements were also higher. Actually, the periodic limb movements were related to strokes in the white matter between the cortex and the brain. We compare these cortical strokes, white matter strokes, or small vessel strokes, and brainstem strokes. In the white matter, we had problems with the REM. The apnea-hypopnea index was very high in stroke patients, the same for snoring index. But the most surprising, this is a snoring patient. These are the number of snores here, which was also higher in patients. You can see that the apnea-hypopnea index was almost 5 or 4 folds more than the obstructive sleep apnea. They had higher central sleep apneas, mixed apneas, while in the hypopneas there was no great difference between both groups. You can compare here the other studies between both groups and see the difference. The desaturation index was the most dramatic difference between both cases and control. The higher the desaturation index, the worse was the outcome and the worse was the stroke patient. As we said, the REM percentage and the REM duration and REM latency was the only parameter differentiating between cortical and subcortical strokes. Thank you for your active listening.
Thank you very much, Dr. Rajana. And now we open for discussion. Let's organize the discussion. First, the discussion would be any question for Professor Dr. Gucci when presented at the first time. So will you please, Professor Gucci, present at any question?
I wonder if some of
I was wondering how much of the PBM and fMRI changes would possibly be causative rather than an effect. Are they all an effect of having sleep apnea, or some of the changes might contribute to the pathophysiology of the disease itself?
It's a good question. We don't know exactly what is the real weight of sleep apnea per se and the other possible factors. We don't know. For this reason, I showed you the last slides that I think that it's very important to consider all the different aspects. For instance, the comorbid condition. We don't know, for instance, exactly what is the possible relationship with the hypertension. This is another important point. We know that hypertension per se, blood hypertension, may cause some changes in MRI. For this reason, I think that we have to consider different groups, different subgroups. For instance, patient with sleep apnea plus hypertension, sleep apnea patient without hypertension, but especially I think that the most important thing is to evaluate the patient in the very early phases of sleep apnea. Because in this way, if we follow this kind of patient, we can know exactly what is the real weight of sleep apnea. It's very difficult. The other problem is that with this kind of studies, that are very expensive, you cannot consider very large population. So this is another important point. But I think that we are trying. Another important study that we are performing right now is the evaluation of the upper airway resistance syndrome patients without hypertension, patient without problem of obesity, and I think that in this kind of population we can say exactly what is the real weight of respiratory disturbances in the developing the possible MCI and so on.
Thank you.
Any question? Yes, Sam?
Usually, as neurophysiologists, we're usually asked, why exactly do we need to perform polysomnographic tests here in Egypt? Usually, patients just skip. I mean, if they feel they're okay, then things are fine, then fine. So, having actual proof that we have neuroimaging changes in like memory deficits, does this apply only to severe memory problems, or just simple? I mean, if someone tells me as a neurophysiologist, I just have a little bit of memory issues, can I advise him that maybe we can see if this can apply to you or not, or that would be like to...
Another very important question, But I think that we have this kind of problem also with other sleep disorders. The problem is that you cannot perform polysomnography in every patient, because the problem is that usually when you ask to the patient, you have a sleep problem, you have a memory problem, the patient says no.
Yeah.
This is the problem, and for this reason I showed you that it's very important to perform just three tests, not all the batteries, because otherwise it's impossible. But I think that is important, because another important pathology that we have is a REM sleep behavior disorder. We have a lot of experience with this kind of population, and if you ask to the patient, you have memory problem? No, nothing. My memory works very well. But when you perform the neuropsychological battery, you can see that there are very, very important deficits, And I think that we have to start to evaluate all of our patients with a very, very simple, short battery from the neuropsychological point of view. Very, very short, because with a very simple test, you can spend just no more than 5 minutes, And I think that we have to, this kind of... Yes.
So you would suggest that this would be after a certain protocol of neuro...
Very, very simple, because you cannot spend a lot of time with each patient. But we know very well that there is a very, very large, very huge discrepancy between subjective and objective findings, especially when we talk about the cognition, because usually also the patient has very, very impairment of cognition. You will say, okay, I have no problem, But if you start with this is the reality every day with our patients. And it's very simple, very, very, just 2-3 tests, very simple tests.
And if the test...
And we have to put, I was really impressed when Badr showed the problem of blood pressure. Blood pressure in every patient, usually we measure blood pressure. Why? We have not to perform very simple questionnaire on sleep habits. I'm not just saying about the sleep specialists, but for all specialists. Very simple questionnaire on sleep habits, a very simple test for cognition. Cognition is very important.
Thank you.
I think also orientation of the problem is very important. To be oriented in the problem is very important.
Yeah.
That's why we are discussing this. Any more questions, please, to Professor Mucci? Thank you very much.
Okay, thank you, Judy. Thank you, Judy.
Discussion, we can move to the second speaker, Professor Dr. Tariq Azhar. So please, any question to Professor Tariq? Any question? I think the lecture was very, very good. Yes, please.
Actually, it's not a question, it's just maybe a request that we as Egyptian sleep physicians need to do something about availability of modafinil in Egypt. That's all. Because narcoleptic patients and OSA patients, just as you mentioned in your lecture, they need it and we don't have it. So maybe the Egyptian Sleep Society, since we have actually established ourselves, we should do something about that. And thank you.
Thank you very much. Believe me, I did a lot of effort. I talked to so many companies, especially the generic companies, but nobody wants to because it's very expensive.
Yeah.
It's now available, especially imported in famous pharmacies like ESSB pharmacy, but it's expensive.
Yeah.
But no generic, local companies, they don't want to produce it. They said how many patients you have, whether it will be cost benefit or not. But
Yeah.
we have to make more pressure. Thank you.
Any more questions? Yes.
I want to ask about the treatment or the psychiatric problem associated with obstructive apnea as regards depression and personality change. Do you need medical treatment in plus CPAP?
Yeah. For especially if it is diagnosed with depression, not just the depressive symptoms, yes, they need. And actually the choice of the medication here is very important.
There is a definite cases of psychiatric disorders.
Yeah. In my study I found the diagnosis of psychiatric disorder, not only just depressive symptoms, because I applied a structured tool for diagnosis of major depression.
No role of CPAP or BiPAP or whatever the devices to control these psychiatric problems.
Actually, after CPAP, the psychiatric symptoms improve.
With treatment or without? As regards blood pressure, sometimes we don't need for antihypertensive drugs in the cases of blood level and so on.
For me, if it is diagnosed with depression, I have to give treatment in addition to the CPAP.
Last question for both. What's your opinion about the condition of impotence or sexual disorders, male and female, especially in male, the impotence as regard from starting from the desire and the erection and so on, the cravings. If there is any effect of CPAP on the treatment of this problem?
Yeah.
After how long?
I don't have an exact figure, but
because
yes,
the patients ask
with the improvement of the clinical condition of obstructive sleep apnea, some of the patients get improved in this without giving any sexual aid.
I have a study in these cases and take a desire to detect if there is an organic dysfunction on those patients or not. It's just hypoxemia or
the hormonal level, the testosterone level.
We have injected penile injection by some material to make an erection. We found there is an organic lesion on those patients in the form of venous leakage. Venous leakage is very important. Sometimes CPAP can improve this dysfunction as regards the endothelial dysfunction or one improvement of the oxygenation. And we are treated those patients for 3 to 6 months, improve, but the others in need for ligation of this venous leakage.
Thank you very much. Question. Very important from the clinical point of view, but actually erectile dysfunction is multifactorial. It might be related to insulin resistance and diabetes, might be related to vascular, might be related to the psychological condition. But I just want to stress here that the mere presence of venous leakage is not indicative that it is organic, because in my practice I found so many patients who are psychogenic. They are really psychogenic, but they have tests that they have leakage. Whether this leakage is affected or not, this is very important.
Yes, Professor.
Yes, I have just a very, very short comment about not about sex and sleep apnea, but about the depression residual depressive symptoms in a CPAP-treated patient. When you have residual depressive symptoms, I think that it's very important to avoid medication, antidepressant medication that can cause a weight increase. Please remember that, because usually also in Italy I saw that several times they made a mistake, because they use antidepressant drugs that can cause an increase in weight. Yes, it is a very crucial point. Avoid this kind of medication, because otherwise
You're absolutely right. That's why I wrote in my presentation the choice of the antidepressant. You will not use here tricyclic antidepressants. You will not use the dual action drugs which produce weight gain. But good antidepressant drugs here are the SSRI, especially fluoxetine and bupropion, Wellbutrin, because it might even induce some sort of anorexia. So it's good, and also it's an alerting drug. It's not sedative.
Okay, thank you very much, Professor. Will you please present? I'm sure there are questions. Before I
I'm sorry for popping up again. I'm just asking Professor Mekti, do you have any experience about epilepsy and OSA?
Yes, we have 4 studies of epilepsy and obstructive sleep apnea. Most of our epilepsy patients were children and adolescents. Syndromic patients are more prone for obstructive sleep apnea. Mental subnormal or structural epilepsy are more prone, they have more obstructive sleep apnea. While idiopathic syndromes, active syndromes show on juvenile myoclonic epilepsy show lower results as regards obstructive sleep apnea. Yet once we have any sleep complaint whatsoever in the course of epilepsy, it should be promptly treated, because it worsens the course of the patient, and they are usually refractory to treatment.
So they are more provoked to epilepsy than protected. By here I mean they are relatively more acidotic. So this could be protected. However, they are drowsy.
Not that protected.
Yet they are drowsy, then they are provoked. So which way does this balance?
It's not this one way, it's a matter of, you're talking about obstructive sleep apnea. It's not about only hyperventilation, hypoventilation. When we have obstructive sleep apnea, we have obstructed sleep, we have interrupted sleep. This will worsen the course of epilepsy. The other way around, epilepsy by itself, it will not trigger a sleep disorder per se. Except if I have a structural lesion, I have syndromic, or I have a syndromic patient.
The next question. Yes, please.
So what happens to stroke patients after 1 month?
After 1 month.
Sleep rate is move around.
That depended largely on the site of stroke itself. For example, patients having strokes in the brainstem, they did not improve. Patients having strokes in the white matter, up in the white matter, they mildly improved. Cortical, as far as it was away from the upper centers of respiration, they markedly improved, but we didn't show any significant differences. It was only a clinical observation. It was a small sample by itself, and some of our patients even dropped out. We needed a longer duration to follow these patients out, not only 1 month.
I think there was a study doing sleep studies immediately after.
Immediately after sleep.
And whenever you discover sleep apnea, you have to put the sleep apnea immediately. And it moves the outcome.
Definitely, it will improve the outcome. And patients treated, those who discovered that had sleep apnea and were treated, they improved markedly after that. And we even followed some of, not all the patients, but some of them, those who were treated showed better rehabilitation. Even the physiotherapy results showed better results. But there were a smaller number that followed after that.
Any questions, please? Okay, thank you very much. And now we declare the end of this session. And please keep seated because we start with the next.
It's a slight change in the rest.
Thank you very much.
First, I would like to thank again our presenters. It was very interesting and well worth being here. I'm sorry about the delay. We're going to slightly change what we're doing. We're going to continue with the presentations for the hands-on workshop, and then take the break and have and set up for the hands-on with different tables in different. We're going to change this room totally. So I take the opportunity to ask, first to ask the chair people, Dr. Ramis, yes. Dr. Sally. And Dr. Levine is here.
Yeah. But I'm not a chairperson.
No, you're not a chairperson, but you're going to present.
Right now?
We're going to start because Dr. Ala asked us if we could start.
Okay, I can do that.
And till we're all set again, I'd like to repeat the objectives of this meeting, really to share the experience with the experts from different parts of the world, to communicate and form network with other societies around the area, North Africa, the Gulf, the Mediterranean area, and international, the World Association of Sleep Medicine. And make sure that we meet again and try to think forward for everybody. We need to set up training programs in sleep medicine for the technical part and the medical part. So we need to find means of accreditation for physicians, technicians, and laboratories. And I think the only way to do that is really to have an input from everybody. And it would be really, I would be very thankful if you could all write back, tell me, when do you want us to meet again? How do you want us to proceed especially for the training and the accreditation? Professor Safwan mentioned that we could write to the American Academy of Sleep Medicine and ask them at least to guide us, to tell us how the society could do that. We could ask Professor Kandi, how can we be members of the World Association of Sleep Medicine? How would that contribute to sleep medicine in Egypt? How would that add to our society? And I leave you with many questions, and I leave you with, please tell us, how can we go forward? We're going to start with Dr. Levine, who's going to mention, who's going to present to us actigraphy. And for all of you who work in Egypt, know that no one uses actigraphs, and very few. In fact, I don't know anybody but Dr. Levine who's worked with actigraphs. So you have one. This is very interesting because it is something that definitely we could do more with. So hopefully we will have just use.
It will just take us a few moments for the presentation to kind of start working, and I just use this few moments to thank the chairperson and Dr. Shahira. And she actually gave me and praised me more than I actually deserve. So I hope this lecture will be of use and benefit to all of you. I'm trying to focus more on the practical parts of the device more than the theoretical background. But to do that, we need to know a bit of theoretical information. Can you hear me now? Okay. So basically, this will cover the technique of uses. What type of data does it record? What's the good things and the bad things about this device? And actually detecting sleep-wake activity by measuring movement has started very far away, maybe in the 20s. And they have, the device depends upon transferring movement into electric pulses, and these electric pulses are then transferred into a software in order to differentiate between sleep and wake. As I said before, it has started in the 20s, and it was actually the American Army which invented the device in its very early versions, and later on development in the techniques and software proceeded later on. You need to just take a look at the picture, maybe. This was one of the early actigraphs. It is still used, but there have been newer models and more updated versions of the device, which we will see later. But this is how the device looks like. So, where should we wear this device? Basically, a lot of researchers and papers have talked about wrist activity. So you just wear it like an ordinary watch because it does actually look like a watch, which tells us the time. So you can wear it on the wrist. That's the major articles. Let's say 90% of the articles mention wrist activity. The 10% remaining of the articles or researchers talk about maybe shoulder, abdominal, or ankle. Okay? You can wear it here, here, or on the ankle, but you just need a bit larger maybe strap or a longer strap that will fit in the whole body or the area where you're gonna place it. Okay? But let's say 90% it's wrist activity. Where on the wrist? Up here or here or here? No, just exactly like you wear your ordinary watch. And it should be on the non-dominant wrist, meaning you should ask your patient whether he's right-handed or left-handed. If he's right-handed, he should wear it on the left wrist. If he's left-handed, he should wear it on the right one. Okay? What does it record? As I said before, it's a piezoelectric device which transfers movement into electric pulses. Okay? And then this electric pulses will go to the software or to the little computer, little chip inside the device, and it records this in order to be able to differentiate between wake and sleep depending upon the movement pattern of the patient. As regards the American Academy of Sleep Medicine practice parameters, there has been 2 papers regarding actigraphy, 2 major guideline papers, one in 2002 and the most recent one in 2007. And they have mentioned a lot of guidelines regarding the use of actigraphy in sleep medicine, but these guidelines are not our topic today, but you should go back to these 2 papers and read them if you want to know more about the usage or the recommendations of the ASM regarding actigraphy usage. And during this presentation, I will present some of the articles or some of the research areas in which we can use actigraphy for sleep detection. You should note that actigraphy should not be used alone as a diagnostic sleep device. Okay? You can use it in addition. Any sleep lab will have so many tools, including polysomnography, portable polysomnography, actigraphy, questionnaires, pulse oximetry. You will have a lot of tools. And actigraphy is just one of these tools. So you can use it, you cannot use it solely alone. Later on, during the presentation, I will tell you from my clinical experience that there are certain sleep disorders which you can use actigraphy alone in it as a diagnostic device. But that's what the American Academy has said. Furthermore, it has no actual value in sleep-related breathing disorders. I think there is one type of actigraphy devices available in Egypt in which you can add further channels to the device. Basically, you can add maybe EMG, you can add pulse oximetry, you can add hypertension, make blood pressure detection. It's just multi-channel actigraphy. But for me, if I'm gonna wire up the patient with less or more electrodes, then I would prefer to use a polysomnographer more than an actigraphy in such case. The most thing that I like about this device is that you have no wires. You will not need to hook up your patient and wire him up, and he will sleep with a lot of electrodes and wires on his body. And this in itself might kind of bias your results. So if you're going to use a device like that, I would not prefer to add further channels to it, but I'm just saying because it is available if you need it. The idea of work is, if you look here, this is supposed to be the zero line or the baseline of any activity or movement. Okay, when activity happens, it should raise above the baseline, right? Okay, and the width is the duration at which the activity happened. So the longer the activity remained, the width of the activity will be bigger. Okay? What about the inert areas in between? It's the area in which no activity at all happened. Most of the actigraphs in the market now are just uniaxial, meaning that they show only the data above the baseline. Okay? And this is quite good for sleep-wake detection. Only one model, and I'm not going to say a commercial name so that you don't understand me or get it the wrong way, but there is only one model of actigraphs which only show the sine and the cosine of the wave activity. So you get the positive and the negative reflection of the actual movement part. And this is good if you need to measure or detect circadian rhythm disorders. So, uniaxial actigraphs will have the baseline and anything above the baseline, and it's good in sleep-wake detection. Triaxial actigraphs will have the opportunity of adding circadian rhythm disorders. Is it clear? Okay. So basically, this is a variety of devices. Some of them are available in Egypt, some are not. And as you can see here, this one, for example, it just has the profile of an ordinary watch. It can tell you the time. So the patient will not be stigmatized by wearing the device, and everyone will ask him, what are you wearing and what's that? He can tell them it's just a watch. Okay, this one, it's one of the channels added for pulse oximetry. So you can have the actigraphy data in addition to the pulse oximetry data, and it can be helpful in sleep-related breathing disorders. Let's see this one. If you see this little thing here, do you know what this is? It's a light detector. So it can measure actually the amount of light which the patient is exposed to, and it's one of the variables which we can depend upon for differentiating between sleep and wake. Okay? This one, it's fairly a commercial one, but it's used by sports sports medicine, they use it to measure the fitness of their candidate before a certain performance, Olympics, for example. So they need to make sure that his movement or his rest activity rhythm is within the needed before he goes to his match or runs his marathon or whatever. Okay? So this is a variety of the devices, and each of these gives us, each one of this has additional options, but there are some basic options which you need to look for in any actigraph, and we're going to know these options in the coming slides. So if I'm going to use an actigraphy with a sleep disordered patient, there are a couple of things which I need to organize and make sure they're done properly before applying the technique with the patient. First, use a diary. You know what a diary is. Yeah. It's just a piece of paper for the 7 days of the week in which the patient writes down his sleep onset, his wake onset, whether the lights were turned on, whether the lights were turned off, if he has conducted any exercise, okay, whether he was resting, just sitting in a restful position without sleeping. He can note these things down, and that's, we're going to know why we need a diary in the coming slides. It's really important. You can use the device without it, I mean, but for me, I need to make sure that my data is correct and reliable and valid, so I need to ask the patient to fill in the diary. The second item is take your time analyzing, meaning a lot of these actigraphy devices, just like the polysomnography, they provide you with automatic analysis. So you just click one button and you get a lot of tables filled with numbers. Again, as I score my polysomnography myself and I don't depend upon the automatic analysis of the software, you need to do the same with your actigraphy data. So you need to take your time analyzing your data and don't depend upon the automatic analysis because it will give you errors. Choice of algorithm. The numbers you get from the device are raw numbers. Okay? We're gonna take a look about how the numbers look like. But these raw numbers, how are you able to interpret them unless you actually have a mathematical algorithm in which you apply these numbers into the mathematical algorithm to get the parameters you need. So basically, if you're gonna measure the sleep time, the wake after sleep onset, whatever parameters you can get from actigraphy, these are not the raw data given from the device. You need to calculate and do mathematical calculations in order to make sure that you have what you're actually measuring. As regards these algorithms, they can differ from a person to another depending upon why are you using the device? What are you looking for? What are the data that are meaningful to you in this particular patient? So you will be able to see whether to subtract a parameter from another, add a parameter to another, multiply something by another. So for me, I have my own algorithms for my work, but it's not something standardized that I can pass on to you or someone else. You need to figure out your own algorithm depending upon why you are using the device and how. The choice of software. Of course, each of these models has its own software, but there are basic needs which you need in any actigraphy device. And in the upcoming slides, you will be able to recognize what are these basic needs. Some of the watches, which are the monoaxial watches, if you're using them for circadian rhythm analysis, you're using the wrong device. Okay? You need to choose the triaxial device for that purpose. What about reliability and validity? We're gonna see it as well. And how do you handle missing data? So, what if the patient takes the watch off for any reason? He's taking a shower, maybe he was sleeping and maybe he take it off and forgot to put it on again. It was raining and he was worried that maybe the device will be damaged by water. How are you going to handle the missing data? You need to have your own algorithm about how to handle the missing data. Are you going to count it within your analysis? Are you going to exclude it? Are you going to count some of them and exclude others? Each case by case, you will need to decide. Okay, so there is no standard method of dealing with missing data, but you need to put it in mind and know exactly what are you going to do in these gaps where the data are missing. Okay? What about event markers? Event markers, just like the light sensor I saw you saw in the previous slide. Event markers, there will be an additional button in which the patient can press when he turns the light on or off, for example, or when he goes to sleep or when he wakes up. He just marks the onset and offset of each activity he does. And that will make things easier, or it will be a built-in diary, if you understand what I mean. So it will not be in a paper form, it will be on your own device. You will not need the paper diary anymore. So, about the reliability and the validity. These increase when the device sensitivity and specificity increases. When we say sensitivity, it means that if you do a polysomnography to that patient, and the periods counted as sleep in that patient will equal the same period of sleep counted by the actigraphy device. The more they come closer to each other, the more the difference between them is smaller, the more sensitive the device is. And this will, you will be able to judge different models of actigraphs from doing this just very simple test. You do a polysomnogram, and he's wearing the actigraphy just next to your wires. And on the next day, you score your polysomnogram, and you score your actigraphy data. And if they are quite close, and the difference is very small, it means that this device is sensitive. What about specificity? This device is specific when it's able to detect the wake periods, okay, just like the polysomnography, and maybe more accurate. Because in actigraphy, it's not an overnight study. So the patient doesn't just wear the device for a single night. No, it's a day and night recording. He just puts it on, like a watch, and you can leave it there for a week, 2 weeks, 3 weeks, 1 month, okay? It's just a watch. And the accuracy of detecting wake versus polysomnography, we call it specificity of the device. Okay, so let's take a look at how this is data from my own MD thesis. I did it at the UK. And we were studying the circadian rhythm disturbances in depressed patients. And we were using actigraphy, polysomnography, and melatonin as detectors of circadian rhythm disturbances. But this is a data of one of my patient or MD candidates. So if you take a look at the black bar here, this black bar denotes the time. So you can see here 12, 6, 12 again, 6, 12. Okay? And each one of these will be, if they are 6, so each one of these will be an hour. So this will be 1, 2, 3, 4, 5, and 6. Okay, so this is the time. The longitudinal axis is the day. So you have here Tuesday, Wednesday, Thursday, Friday, Saturday, and so on. And this patient has been wearing the device for nearly 3 weeks. Okay, so this is a 3-week data. Let's look here. You can see a lot of very dark black areas, yellow areas, areas where the black is nearly absent, okay? And also the yellow is absent. So what does this mean? The dark black is where the patient is really active. So the device is recording strong activity. Less dark areas or nearly absent dark areas means that the patient was inactive. And yellow is the presence of light. So basically here he was exposed to light, while here he has no exposure of light at all. And then here he started to be active again, and he turned on the lights, okay, and so on. So how am I gonna explain this or interpret this? So on Tuesday, this patient went to sleep around 2:30, okay? Remained asleep from 2:30 until around 11:30, and then he woke up, okay? And during his sleep, he had the lights turned off. And during his awake period, he had the lights turned on. And so on in each of these days. If we look to the next graph, this red line, I drew it by my hand. I did it my own just to show you that sleep onset and sleep offset or wake onset is just like a zigzag line, which means that this patient had apparently you all fell asleep. This patient has a circadian rhythm sleep disorder because his sleep onset and wake onset are not in a routinely constant way. It keeps shifting, okay? And you will be able to tell the difference when you see the next patient. This was not a patient, it was a control, normal, healthy, not complaining of depression, and not complaining of circadian rhythm disturbances. And if you look to the graph, at which I have done it by my hand as well, you will see that this patient is nearly keeping his sleep onset and wake onset routine. You will find the lines just going down nearly parallel, and he has no circadian rhythm sleep disorders. I will pass on these because there is something else I need. Yeah, this way. So this is a window in the software which I was using. Okay, and this here is just a little area from the plot you saw in the previous slide. analyze. So if you start here, for example, and just click, and end here, for example, and just click, certain numbers will show here, okay? And you need to copy these numbers into an Excel sheet in order to do your calculations and algorithms later on. So depending upon the area you choose in the plot, these numbers will differ. And you need to know which area from the plot you're gonna analyze. And why did you choose this particular area? And according to the numbers, you will later on do your calculations. Is it clear? So let's go back. What do you think? This is not my data. It is something I downloaded from a book. It's not my own data. But what do you think about this actigraphy? What does it tell us? What do you think? Regular sleep onset and offset periods? No. Okay. Regular sleep times? No. So, regular activity restraints? No. So this is a shift worker. Okay? He sleeps sometimes during the day, sometimes during the midday, sometimes during the night, sometimes during the afternoon. Okay? It's a shift worker. Okay, what about this one? Come on. You're supposed to be actigraphy experts now. What do you think about this one? Come on, where is the sleep onset? Where is the sleep onset? It's around 5 a.m. in the morning. So what do we call this? Someone who starts his sleep in 5 a.m. in the morning and wakes up what time? Okay, and he woke up around 2 a.m. in the morning. We call it one of these phase shift things. What? Exactly. Okay. What about this one? Sorry. Well, it's just written, but this is an example of an insomnia patient. Okay? So, I'll try to speed up because I think I've taken more than my recorded time, but I'm trying to give all my information, okay? So what are the circadian parameters that you need to calculate? Intradaily stability, okay? Intradaily stability means the stability of the wake activity rhythm between the different days of recording. Intradaily variability is the variation of sleep activity rhythm between the different days. L5 is the 5 hours in the day where the patient took his maximum light exposure. Okay? You need to go back to the sleep analysis window, get your numbers, start checking where is the highest, and you will know the L5, the highest 5 hours containing highest numbers of light exposure. When does this 5 hours start? When does it end? It's the L5 onset. N10 is the minimum 10 hours where the patient is exposed to light, and this is usually during sleep. When does it start and when does it end? The amplitude of the rhythm and the relative amplitude of each day to the other one. And each of this has algorithm for calculation, and algorithms are not constant, as I said before. You can change them. And this is how the circadian rhythm analysis looks like. And if you match this, it's just a curve, right? Curve starts, goes down, and then starts again and goes down, and so on. I will finish now.
Just 1 minute.
Yes.
If you can wrap up in 1 minute.
Yeah, I will do that. I will just show you some of the studies which you can use actigraphy for. Insomnia, sleep breathing disorder, narcolepsy, sports, children, ADHD, autism, periodic limb movement, and you will wear it on the ankle, not the wrist. And maybe finally, I will not be able to finish all what I need to say, but I think I gave you the major idea behind the device. And thank you very much. And so sorry for maybe taking more than I actually need of time. Thank you.
On behalf of the organizing committee, we apologize for the delay throughout the day, but we're going to try to catch up, inshallah. I will try my best to speed up a little bit so we can catch up, so we can have more time with the hands-on and the next presentation. العصر الصحيان. ده كنت حضرتك كنت عاوزة تضربيني ولا ايه؟ لا بالعكس كنت بحضرتك لان انا مع حضرتك في حضرتك. طب العصر الساعة كام عشان نتهايم الوقت عشان الناس اللي عاوزة تصلي؟ الساعة 2:30. طيب. ان شاء الله هنحاول نخلص في وقت مناسب بحيث ان الظهر ما يفوتش اللي لسه ما صلوش. My talk today was written in the paper as CPAP and PIPAP. Actually, it's a little bit more than that. It's the management of sleep apnea. We heard a lot about how we diagnose sleep apnea. Now, how are we going to manage sleep apnea? There's different ways of managing sleep apnea, the surgical and the non-surgical. There are some surgical procedures that we can do in certain patients. There are non-surgicals. With the non-surgicals, usually when I analyze the polysomnography and I analyze the patient weight, I try to look for the least invasive. The least invasive will be weight loss if the patient does not have a significant sleep apnea. The second will be the weight, as I said, weight loss, positional therapy. Some patients will snore in certain positions according to polysomnography. Sometimes they do not snore. They're just experiencing a little technical difficulty. They're working on it. Don't worry, I'll catch it up. Then after that, if the patient have the severe sleep apnea, the mild or moderate or severe. With the mild sleep apnea, we're going to treat them with a CPAP. CPAP is a gold standard for treating all the patients. We always encourage to start the CPAP. If the patient failed the CPAP, then that's a different story. Then we have to look for other avenues. The other avenues will be the oral appliances. The oral appliances come in two different versions. The one that the patient put on their mouth, which is like dentures, or the tongue. Oral appliances, زي ما قلت, the mandibular retaining device, which basically pushes the lower jaw forward, so it allows more passage. The other type is a tongue retaining device, which holds on the tongue. It's kind of a sucking device that sucks on the tongue and pulls the tongues forward as well. When you consider the oral appliances, before you think of that, you have to do a complete oral exam. And sometimes you need to send the patient to a dentist to help you out. You have to have at least 8 teeth that are present. If it is done, it has to be followed because it can cause malocclusion. If the patient has trigeminal neuralgia, it can worsen that as well. You need to have the anterior jaw, you have to look at the jaw, and there has to be a forward movement of 5 millimeter, and the opening of the mouth has to be more than 25 millimeter. The side effects, a lot of salivations, facial pain, worsening of the trigeminal neuralgia. So if you have a patient that you find in the sleep study that they have paroxysm, they bite on their teeth, then these are not a good candidate for the oral appliances, but you can try some of the other biting device that they can bite on. With the BAP options, if you look in the middle, for obstructive sleep apnea, we can use any PAP according to the scenario. There is a scenario that the patient will tolerate the CPAP, then that's fine. There's another scenario that the patient might not tolerate the CPAP. Or a patient for financial cost cannot come for the second night to do the to do the CPAP titration. So what I would do, I would start them on an auto CPAP, and I'll give them the auto CPAP, send them home, and then I get the CPAP, and then I download the information and I analyze it, and then I give them the regular CPAP at a certain set pressure. There are some patients that will not tolerate both, then these are the ones that I will consider titrating them on a PIPAP. There is no superiority of the PIPAP over the CPAP when it comes to non-tolerance. The other type of sleep breathing disorder that we deal with is obesity hypoventilation. With obesity hypoventilation, these patients already have a high PCO2. Their pH could be normal, but they already have a high PCO2. And if we leave them continually, they will have their PCO2 elevated. So what I usually do, I start them on a BiPAP or bi-level, because as Dr. Patty said earlier, BiPAP is actually a brand name for Respironics. So it's a bi-level, or I start them on a bi-level and ST. If they have a complex sleep apnea, and I'll come to the definition of the complex sleep apnea later, but if they have complex sleep apnea, then I can start them in an auto-SV, which is adaptive cervical ventilation. If they have Cheyenne-Stokes, and I'm going to come to that later too, so let me skip it here. If the patient is narcotic or tramadol, then they will have central sleep apnea. For this central sleep apnea, I'll come to it later too. There are some hypnograms that I wanted to share with you. The patients who have COPD and they have the overlap syndrome, then generally I would prefer to have them on a PIPAP. Doesn't mean that the CPAP is not working, but if I do the CPAP on them, it has to be monitored. I would not give any patient an auto PAP in any form if they have heart failure, if they have stroke, if they have COPD. And there's one more that's skipping my head now. Obesity hypoventilation. Thank you. Generally, for the titration, the protocol that we set is we start at 4 centimeter. The C-Flex or the C-Flow depends on the brand name that you have. Right now, most of us use either Resmed or Respironics, McDonald's or Hamburger or Burger King, or whatever you want to name it. So you start. If there's no events happening, then I would stop. But generally, most of our patients will require more than the 4. If I do have an event happens, then we go by 1 centimeter, and then we wait for 5 minutes, and we continue till we reach what we want. If we reach the 15 centimeter, this is when we need to make a decision. Are we going to switch and start a PIPAP, or this is where we're going to stop? And generally, this is where I get a call from my sleep technician at 5 o'clock in the morning. Doctor, again, what do you want to do? I say, I want to go back to sleep. So I'll tell him, follow a PIPAP protocol. The PIPAP protocol, usually, if we're making the conversion from a CPAP to a BiPAP, then whatever we reached at the, in my lab, whatever we reached at the CPAP, that's where I will set the IPAP, and then I'll drop by 4 for the EPAP. If we're starting from the beginning, generally, 8/4 is a general good start. If there is obstructive events, then the technician will go up on the EPAP. If there is any other events, then we go up on the IPAP. Now, as I said, my sleep technician called me, but this was early in the beginning of the night. He told me we have 3 seconds of arousals. You can see them there, Bob. He said that we have hyperventilation, and we have central apnea. Can I get a consensus from you? I'm going to ask the question and I'll say, tell me what you do. How many of you will tell the technician, go ahead and start BiPAP, this is a clear central apnea? Is that nobody wants to respond, or you're reading, all of you know sleep very well? Okay. How many of you tell the sleep technician, oh, stop the study, this patient is too risky, send him home, or her home? Okay. How many of you tell the technician, continue the night and then call me later? Okay. Because this is happening in the beginning of the night, and there is an arousal that's happening. With the arousal, there is hyperventilation. With the hyperventilation, the CO2 goes down. So when the CO2 goes down, then the patient threshold is reset. There has to have a central sleep apnea. There has to be a signal to stop respiration till the CO2 goes back up to normal. So this is a normal physiologic response. If it happens at the beginning of the night, I would not treat it, I would not do anything. Okay, 35-year-old male with back pain, snores, complains of daytime sleepiness, on tramadol or another narcotic, and you see the top portion. Don't look at the bottom portion, look at the top portion. What do you think that this patient have, or what would you do for this patient? Again, the same questions. Would you not do anything? Would you start a BiPAP? Would you start a CPAP? Would you start an adaptive servo ventilation? Okay. The trick here is ignore everything in this question. Everything is a distraction to distract you from the right answer. The right answer, this patient on pain management. So patient develops central sleep apnea secondary to opioid use. So the first thing that I will do is I'm going to call the pain management doctor and tell him, can you back off on the pain management? And that's what happened. When they backed off on the pain management, the central apnea has disappeared. If they say that we can't, then I have to start looking into PAP therapy. There are some patients that are really bad that you can't back off on the medication. And if this happens, then that will be the alternative. Okay, that's a 65-year-old male admitted to the hospital with pulmonary edema. You want to call heart failure, that's fine. And the patient was treated and discharged. You did a sleep study because you're a great doctor, and you find this. First, what do you think this is? Cheyenne stroking, great. And where do you think that what would you do here with a Cheyenne stroking? Would you, again, do the CPAP? Would you do the BiPAP? Would you do the adaptive servo ventilation? Okay, this patient just left the ICU or left the hospital, and this was done outside. So the first question, I agree with you, review the medication. If the medication and the patient was optimally medically managed for heart failure, then you're going to have to treat with adaptive servo ventilation. But if the patient is missing diuretics, missing ACE inhibitors, maximize your medical management for the heart failure patient first before you start the PAP therapy. Complex sleep apnea. I got asked that question about 10 years ago when Dr. Suzanne and I were talking, and she said when we treat the patients, we start looking at, we're finding apneas happening more and more. And that's what's called the complex sleep apnea. The complex sleep apnea is the emergence of central apneas after initiation of CPAP. What would you do when it happens? A lot of them will disappear. If you back off on the CPAP to the pressure before, it might disappear in the night, but a lot of them will disappear in 3 months. So if I'm doing well and I'm not bothered by the study, I will try the CPAP and I will see how the patient will respond to that. You can use the adaptive servo ventilation in these cases. It's indicated, it's approved. And you can use it for the Cheyenne stroking as well. The adaptive cerebral ventilation, as I said, it's approved for the complex sleep apnea. It's an automatic pressure support. It's dynamically set. You ask the patient to wear the mask, breathe at the beginning, and then it will fix the patient. We have the Respironics brand, and we have the ResMed brand. I'm not biased by either one. Both of them work. It depends on what's cheaper, what's available. In this, I use this example, but the patient had the apneas and then they had the hypopneas. When the adaptive cerebral ventilation was utilized, here you can see that the hypopnea disappeared and the patient had a nice wave. In here, when the adaptive cerebral ventilation was stopped, the same events recurred. Done with the treatment, need to continue managing the patient. In the United States, we have to follow the patients. We have to get the insurance company paid for the equipment. Patients don't buy the equipment from the get-go, like here. So I have to follow the patient. One of the common mistakes that I see, or one of the things that gets me upset, is that the company that gives the CPAP tell the patient, you need to wear it 4 hours. After 4 hours, you don't have to wear it. And you have to wear it at least 80% of the times. And it's usually an argument between me and the company. And I have written a protocol now to the companies not to instruct the patients. Because I talk to the patient and say, if you have a high blood pressure, do you take your medicine 80% of the time? No, you take your medicine every day. Do you take half a tablet instead of a tablet when a doctor tells you a tablet? No. Then you need to wear this the longest, anytime you go to sleep. One of the things that patients correlate wearing the machine to nighttime. I counsel the patients and tell them, you gotta wear the machine when you sleep, if it's a nap or at nighttime. So, skip this. This is a slide summary for the treatment of obstructive sleep apnea. It's simple and fast read. So, lifestyle modifications, CPAP or bi-level therapy, or oral appliances or surgery. What I would like to comment here on surgery and oral appliances, if the patient has severe sleep apnea, don't even think about it. If the patient has mild sleep apnea, then maybe. Moderate, maybe. Why? Because at best, when you have the good correction, you improve the patient's apnea hypopnea by 50%. So if the patient has an apnea hypopnea of 50, and you send the patient for surgery, then their apnea hypopnea is 25, then you're still going to need to use a CPAP. A lot of counseling I do for the bariatric patients. Some of the surgeons, they're surgeons, no surgeons in the room, right? Okay, good. So they're surgeons. They tell the patients, oh, everything is going to be fixed. Your diabetes is going to go away. Your hypertension is going to go away. Your apnea is going to go away. You're going to get rid of that nasty mask that your pulmonologist wants you to use. It doesn't happen. I study the patient. And at best, the majority of the patient, after they reach their target weight that they wanted to lose, they will still need the CPAP pressure, but at a lower pressure. And it can be at a significantly lower pressure. After almost 20 years, 15 years of practicing sleep medicine, I have not taken any patient who went on bariatric surgery of their CPAPs. I lowered it. There are some patients who stopped using it. They said, we don't snore anymore. I said, I don't care about snoring. Snoring is a symptom, not a disease. I don't want to treat a symptom. I want to treat a disease. And then I have them sign a medical legal paper against medical advice that they voluntarily stopped the CPAP against my medical advice. If they are drivers, I report them to the state. Because these people should not be driving. Okay, now I have plans to go over the anatomical parts because in the workshop that we have today, we're gonna have the transnasal endoscopy, which examining the nose. When we have patients who cannot tolerate the CPAP, we're gonna find out, is there a problem in their passage or not? I don't do that as a routine, but I do it in some patients that I think that they might have a problem. Deviated septum, constant complaint of chronic sinusitis, hoarseness, I picked up 5 throat cancers by doing this on the patients. I'm going to skip it for now, but I'm just going to go through some pictures where the most common obstruction is going to be right here, either in the retropalatal area, followed by the retroglossal area. So right behind the palate or right behind the tongue. These are the 2 areas where the common obstruction is going to be. When I'm doing my endoscopy, I'm taking a look. The quality of the picture is not great, but this is the turbinates. This is the septum. This is here the nasopharynx, and you go to the velopharynx, and then you start looking at your uvula, your epiglottis, and you take a look at your vocal cords here, and you take a look at the base of the tongue. Look at the vocal cord motions. The Mueller maneuver is basically here in the velopharynx, and I'm asking the patient to sniff. There is a lateral airway collapse. You can diagnose a sleep apnea that way, but you can't tell how much pressure you're going to give the patient. You can make your diagnosis that way. This is different than the sleep endoscopy, which they put the patient under anesthesia and they do evaluation. I do this while the patient is awake. Then here it shows you, this is the patient, and here after I ask them to advance their jaw. When they forward their jaw, there's definitely improved in the patency. And I'm almost done. I'm just going to set the stage for Ahmed, who's going to talk about training physicians and technicians, getting accreditations. Hopefully, this is an interesting topic for you too. Wake up. I'm sorry. Don't sleep, please. So in 2012, we took the Stop Bang questionnaire. We translated it into Arabic. He published it, was my name on it, added to it. And actually, it's a good translation, and it has been validated. So from that one, we published another abstract where we used the Stop Bang questionnaire in the clinic to screen the patients instead of the Epworth Sleepiness Scheme. And it has been giving a good result. In my mind, to finalize, sleep questionnaires, the physical exam, the experience of the physician will increase the high probability thinking that this patient has the disorder. Then you send the patient to the lab. Not everybody comes in, get to the lab. You gotta do the homework. Well, thank you for everything. I didn't get a chance at the beginning to thank Dr. Shahira and the organizing committee, but thank you for always having me here and giving me the pleasure to be with you. So now we'll move forward for Ahmed to give his presentation about accreditation and training. 16. أنا أصله جامع. حاولت والله أخلص بسرعة.
Any questions for the speakers? Okay, keep the questions there.
I technically don't have any scheduled time anymore. We're way past the scheduled time. So I'll try to go as fast as I can. And of course, they put me in between lunch. I know everybody's hungry. My name is Ahmed Al-Gindi. I'm a registered polysomnography technologist and a registered sleep technologist. I'm the technical director at Florida Women's Sleep Associates in Florida. First of all, I want to start and explain to everybody what all these acronyms mean. We're talking about way too much. RBSGT, RST, ASM, AST, OSA, AHI, RDI, and add everything else into the list. So I'll start with what's in my name. RBSGT is a registered polysomnography technologist. It's a certification given by the Board of Registered Polysomnography Technologists. It's an examination that we have to take, and we're going to go over that in a little bit. The other one, the RST, is a registered sleep technologist given by the American Board of Sleep Medicine. The ASM is obviously the American Academy of Sleep Medicine that sets all the standards in the United States, and it gives us the practice parameters that we go by, and it's basically the foundation of sleep medicine in the U.S. The AST is the American Academy of Sleep Technologists, and they also are the foundation for sleep technologists rather than sleep medicine in the United States. Now I put on here the EPC, the Educational Products Committee, because I am part of that committee in the United States where we develop educational products for technologists. Most recently we developed new flashcards that technologists use to study for the board exam. Other than that, we've created examples of the policies and procedures to use in the sleep center. Today I'm going to go over a little bit about the history of sleep medicine, the importance of technologist training, how to get physicians and technologists trained in Egypt, the importance of sleep center accreditation, and how to get centers accredited in Egypt. First of all, yesterday I went to the Egyptian Museum, Tahrir Square, and I learned a lot of new things. Even though I went when I was younger, most of it I didn't remember. So I'm very grateful for the trip, and it was a nice refresher. I was taught this yesterday that the pharaohs, they're the first people who discovered the circadian rhythm, and they told us that this was a 24-hour clock, and you can see it by the hands. If you count the hands, there are 24 hands on the outer side, and then if you count the red donuts, I guess, those are the 4 seasons, and inside the center they had the horoscopes. So that's a little bit of where the circadian rhythm and sleep started. For technologist section, the scoring started by the R&K manual back in the 70s. Most recently, the ASM updated the scoring manual in 2007, and they have done a couple of updates since. I want to start off by saying, what is a sleep technologist? This is the definition by the American Academy of Sleep Technologists. But in summary, the sleep technologists are basically the people you rely on during the night to perform the sleep studies, or the polysomnographers. Of course, you can rely on them during the daytime to educate the patients, because we know that the physician's time is valuable, and there's no way that you can see and educate and treat all the patients that are needed. So this is kind of giving the technologist some responsibilities to take off your time and give you some extra time to be able to focus on more important things. Of course, the importance of training anybody is to have the quality and knowledge. The other thing is, as long as you have the knowledge, you can increase productivity. The other thing is having consistency and standardization amongst all sleep centers or amongst anybody who's doing anything. Of course, there will always be variability, but what we try to do is to keep everything as standard as possible, so when we're looking at research and things like that, we can understand where this data is coming from. If you have somebody who's trained and you can rely on, you don't have to supervise them as much, which in turn gives you some cost savings. You can go do other things, take care of other people, and of course, reduce frustration. Nobody wants to call in the middle of the night, the technician asking you, what should I do, what do I need to do? The patient is, whatever, complaining of something, they should be able to take care of it themselves. Now, how can we get physicians and technologists trained in Egypt in sleep technology? First of all, what we need to do is set up a training program, and based on the need, you can set that up monthly, quarterly, weekly, whatever it is. We can do that in workshops or webinars. The internet has made the world so small now, we can even chat every single day, every single minute, send messages instantaneously. So that has something that facilitated everything. The other thing is getting after the people trained, we need to get them certified and prepare them for the board exams. Like I said earlier, there's 2 pathways that we can take, the RPSGT, or Registered Polysomnography Technologist, or go the RST route, the Registered Sleep Technologist. Both are 2 different boards. They have different requirements. They both can be met, maybe one more difficulty than the other. The RPSGT needs a minimum of 546 hours of clinical experience that include on-site polysomnography duties performed as direct patient reporting and/or scoring. So what the technologist needs to do is to keep a log of how many hours they've worked and how many sleep studies they've done. Of course, this will be under supervision, And then when doing the application, it will be submitted with an attestation that they've done that. The other thing that they need is a BCLS certification or its equivalent. For the RST, which is the American Board of Sleep Medicine, the minimum requirements have to be completed in an ASM accredited sleep center, which our center is in the US, over a minimum of 3 months to 2 years. You have to do 25 overnight sleep studies. Of them has to be a minimum of 10 for CPAP titration, do at least 1 MSLT, and participate in the Interscore Reliability Program. What that program is there's a quarterly quality assurance that we do. What we do is we have the board certified sleep physician score a sleep study, and then the technologists also score the same sleep study, but nobody knows who scored what. So, and then the results are compared. For this exam, the requirement is that you have to be above 80% in agreement for at least 2 months. Now, the requirements may seem a little bit difficult to attain at first, but I'm always here available to help, and we can facilitate everything as much as we can. Further requirements, the RPUST has an application fee of $450. There's no set exam day. You can take the exam as soon as you're ready. The exam consists of 200 multiple choice items, 150 of them are scored, 50 of them are pre-test items that they do some statistics on. The RST is an application fee of $250. It's only given 4 times a year, so you have to be prepared and submit your application before the deadlines if you want to get into that window. I've set up a curriculum for training that we can go over in the workshops or the webinars that we'll go over. This is basically what will be on the board certification exam. Most of it is basic common knowledge that every sleep technologist should have. So first is the performing the sleep studies, electrode application, putting on the electrodes during the sleep study, interventions, what needs to happen with the patient, CPAPs and things like that, how to take care of the patient, recognizing artifacts during the sleep study to be able to fix them, diagnostic protocols such as just the sleep study or MSLT and MWT, instrumentation and signal processing is understanding the signals and things in that nature. Sleep center emergencies is an important part also. You need to have the technician recognize if there's a life-threatening cardiac event that's going on or if something goes on with the patient, if they'll be able to respond. That's why the BRBT has the BCLS as a minimum requirement. In our sleep center, most of us are ACLS certified, Advanced Cardiac Life Support. And post-study activities, how to take care of the patient. Also, we need technologists to know how to score the sleep study. So we need to teach them sleep staging, recognizing the waves, how to identify the respiratory events, movements, such as periodic limb movements, restless leg, the difference between both, cardiac events, pediatric scoring, if you guys will be doing that, and then also understanding the sleep disorders. We can't just have them be doing the sleep studies and not understand what they're doing. So we'll give a little bit of overview of what is obstructive sleep apnea and other sleep-related breathing disorders, such as Cheyenne-Stokes, because that's also an important part and requires some skill in the titration. Sleep-related movement disorders, like we said before, periodic limb movement or restless leg syndrome, hypersomnias, pediatric sleep disorders, insomnia, and parasomnias. This is a little bit of the reading list that of books that we would use. ASM scoring manual is a cornerstone of everything we do. It gives us the rules on hookup, the rules on scoring, and things like that. They also have a handbook on understanding how to implement the ASM scoring manual. There's also the International Classification of Sleep Disorders, the ICSD, published by the ASM. There's version 3 out now that it gives an overview of all sleep disorders and how to treat them. The ASM, like I said earlier, publishes practice parameters. As in the actigraphy, we heard that there's 2 practice parameters for the actigraphy. There's many others for everything else, obstructive sleep apnea, sleep studies, essential sleep apnea, and things like that. Also, finally, there's a technologist guide to performing sleep studies. I saw Dr. Loza had a little book published about that, so it's very similar to that. It's great that it's in Arabic now, so we can facilitate that. After we get the technologist certified, what we need to do is to have continuing education courses. For the board itself, they require 50 CUs or CECs, whichever way you want to look at it every year. Also, that's something that we can facilitate, and maybe we can have the industry sponsor that also. I want to go over some of the questions that they go over in the exam. So the first question I have is the right electrooculogram electrode. Where is it placed? B is correct. A flattened nasal pressure signal is thought to indicate what? D is correct, airflow limitation. Maybe you guys should get into the exam. This next one is saying that the epic right before this was scored as stage 2 and 2. What would we score this epic as? It's wake. If you notice, starting the first third, there's increased alpha activity, and the majority of the epic is in alpha. And also there's an increase in the chin muscle tone. I also wanted to go over real quick some artifacts. This is something that technologists should be able to identify during the night and fix, so that when we come in the morning, we don't have to deal with all these different weird signals and get a clear idea of what the patient has. So this first artifact, if you can see, the EEG is swaying up and down, and this is a sweat artifact. What you need to do is either lower the air conditioning, or get a fan, or you can try to reapply the electrode using some alcohol pads, but most important is to get the patient not to sweat. Now this one is supposed to be a respiratory signal. It's not smooth. As we can see, it's going up and down, and it has some spikes in the middle. So it's either a defective respiratory sensor, it's not plugged in right, so it's something that needs to be taken care of. This one, if you notice at the top, the 5th channel, I moved that up to match up with the EEG. In this case, what happens is the electrodes are sitting behind the patient, maybe behind the patient's chest, and when they breathe in and out, it moves up and down. So it's something subtle that it kind of annoys the person who's scoring. This one is electrode popping. If you notice in the beginning and towards the end, the signal just pops up and down like that. This can be easily mistaken for a K complex, so that's why training is really important. This is also another example of electrode popping. This is a pulse. This is different than the EKG artifact. If you notice, it's just bumping up and down with the pulses. So that can also be sitting right behind the patient, or the patient is laying on the electrodes or something like that. This is an EKG artifact. That's because when applying the electrodes, it was too close to an artery, so it's picking up some of the EKG signals. This is also another example. This is an example of a pacemaker going off. There's really nothing to do about that other than being aware of it and seeing if the patient needs any assistance. If you notice here on the chin channel all the way at the bottom, it's mimicking some snoring. Sometimes you can't do anything about those, but it's probably a severe apnea patient. This is a 60 hertz artifact. That's when the electrodes are too close to an electrical outlet or something giving out electricity. The best thing to do with that is figuring out what is giving out that signal and trying to take care of it. If you can't do that, then there are some filters that you can put on, but first what you want to do is to take care of the problem. This one is a messy epic. The patient was moving around. If you look all the way at the bottom, the leg movement came on after the patient moved to their left side. So also that's an important thing that the technician needs to notice when the patient is moving around in the bed, what came off, what stayed on, so we can have a clean study that we can use. This is amplifier blocking. It's blocking the signals. This is a respiratory signal. Most of the time what you can do with these on the digital systems is just reduce the amplitude so you can see the whole signal. This one, the head box came off. Hopefully that doesn't happen commonly, but if that happens, you need to check the cable, the main cable, see if it's still connected. Next, I wanted to talk about the importance of sleep design representation. Obviously, it demonstrates commitment to high quality standards, and like I said before, just as we train technologists, we need to make sure that the centers have a set standards that they go by. It shows consistency when we publish research. We can know where these studies came from, what protocols were used, and things in that nature. How to get sleep centers in Egypt accredited. What we're going to do is we're going to start by training the sleep technologists first, make sure we have the support staff needed, and then what we'll do is we're going to develop some standards, and then after that we'll start sending out invitations, getting applications, and start scheduling site visits. This is supposed to be to help sleep centers get them up to par with the standards and have a good sleep centers in Egypt that can publish reports and be respected all around the world. And thank you for listening. If anybody has some questions, I'll be at the
Any
workshop.
question to the speakers? Yes.
I have a comment. To begin with, thank you very much for this wonderful presentation. And I think everyone in this room who is involved in sleep medicine and has a sleep lab appreciates how important it is to have good technical support. It makes all the difference. And I really appreciate what you've done and what you've presented to us. And hopefully, I also want to tell you that Ahmed is a member in the Egyptian Medical Society, and his goal is to make sure that Egyptian sleep technicians are very well trained, certified, and I wish him the best of luck. And thank you.
Thank you.
Any question to Dr. Mahmoud or Dr. Ala?
I have a question for Ala. Ala, you talk about the Arabic version of stop time questionnaire. What's your experience about Berlin questionnaire?
I don't use a Berlin questionnaire. I didn't need to. It's a good questionnaire. There are at least 10 good questionnaires that can be used. But Berlin, it didn't happen to be one of the ones that I used. No, I didn't use it. I just did not use it. I'm not against it. I'm not with it. But I just did not use it.
Okay, tell us about your experience.
Yeah, tell us your experience with it. If you use it, yeah.
Yes, we use it in our
Sure.
lab, yes, and we have our Arabic version and we publish it in the Journal of Clinical Neurophysiology. So I will asking you about your experience with it. Even in America, you have worked with it or not?
Some sleep labs or sleep centers would use it. But the most of the people that I know and my colleagues in the area where I practice, we use either the Epworth Sleepiness Scale or the stop bank. Most of the anesthesiologists use the stop bank. It's in my mind, it's a time-consuming questionnaire.
Yes, it is long.
Yeah, and
yeah. Berlin is a long one.
Yeah, and the stop bank, we were able to achieve what we wanted with the stop bank. Once again, in my mind, if you examine the patient, if you get the history from the patient, almost 99% of the time, when I'm sending the patient to the sleep lab, my high probability before the test is very high. So the questionnaires, regardless of what it is, it's another tool that adds to the clinician skills.
Going back to the stop bank, I don't know if you're all aware, in March there is the World Sleep Day. And again, one of the goals is that Egypt will always be on that World Sleep Day and do something very positive or get the good. And one idea was to use the stop bank in various clinics and get back feedback. It's a short questionnaire. We would be honored if you'd let us use it.
Sure, you can use the Arabic
version. And since we're all here, it would be a good thing to use that and use whatever we get from results on the World Sleep Day. We put Egypt on the map.
It's nice. We have two Arabic versions of two questionnaires. Use what you want of the one.
But for the World Sleep Day, we will need to all decide on one questionnaire to send out to physicians. The Epworth is also translated.
Epworth is also translated and validated by the Lebanese.
Stop by
Yeah,
this.
but I know they took it from here or not, but they published it. They published the validation.
I have no experience with it. It was, I was very
Right. Any other questions for Dr. Naveed? I was just wondering, I wanted to ask you something myself. You know these new bracelets and sleep gadgets that everyone is buying now? Many of our patients come and say, does this report sleep accurately?
Yeah. Well, actually, there is also a smartphone application which you can download for free, and it will do the same work. But we're talking here about professional sleep analysis. This will just track its sleep and wake rhythm, but it will not give you professional data which you will need for diagnosis. Okay, so no, it will not do that.
It will also be a lot cheaper.
Yeah, it will be cheaper, but it's not accurate. You will just play with the application, you can download it and put it on your smartphone and use your mic as a snoring detector or noise detector, and in the morning you can just see your own actigraphy. But as I said, it's not a professionally designed application.
Okay.
I would like to ask Dr. Naveed about the use of actigraphy in patients with excessive movement during sleep. Does it have some fallacies with wake sleep cycle or interpretation?
Well, there is a version of the actigraphy, as I mentioned, to detect restless leg syndromes and periodic limb movement, which is the, let's say, the terminologically defined movement disorder or sleep-related movement disorder. But of course, if your patient is fidgeting while he's asleep, this might give an error in the actigraph that he's already awake, but you will depend then on the light and his diary to be able to differentiate. If we had some more time, I would have gone through the actual analysis, but maybe in upcoming workshops or other time.
سامحوني بس انا هقول كلمه بس بسيطه جدا. انا عايز اهني الدكتوره شهيره لوزة بجمعيه، اول ايفنت للجمعيه، ويعني انا مش عايز اخد وقت عشان عارف ان الوقت معدي يعني. انا بس كنت عايز اقول ان انا اكثر حاجه النهارده تسعدني يعني ان انا حاسس ان في اكشوال كوبريشن ما بين البلمونولوجي والنيورولوجي بصوره واضحه جدا لاول مره في الورك شوبس على مدى 13 سنه 14 سنه، واحنا بنحاول كده. كنا دايما بيبقى الورك شوبس بتاعتنا كده سيبريت يعني، لكن الكوميونيكيشن ده يعود الحقيقه بفضل كبير للدكتوره شهيره، فانا اشكرها جدا الحقيقه، وعلى الضيوف طبعا اللي حضروا معانا، وحتى الاودينس ما شاء الله يعني العدد I think this is the first time to see this يعني. وطبعا اشكر معلش يعني لازم اقول شكر خاص لاساتذه الصدر المتخصصين في هذا المجال، الدكتوره سوزان، الدكتور محمود ابراهيم، الدكتور اشرف، الدكتور اكمال طبعا على الحضور يعني. ثانك يو فيري ماتش يا دكتوره شهيره الحقيقه، وبالتوفيق ان شاء الله رب العالمين. فيرست ايفنت فيري جود.
لسه ما خلصناش.
اذا انا عارف
الهاندز اون، بدل ما ننقل كل حاجه لهنا وننقل جزء وما ننقلش الجزء الثاني، هنروح من الاوضه اللي فيها الريجستريشن and we form smaller groups and rotate. علاء مع احمد and other action and industry will see us through the different products, and if we have any questions I can address. حضرتك هتورينا الاندوسكوب كمان؟
هو ممكن هو جه بس قطع شوفه فين، لو يكون طلع في المقابل او راح في القاعه
عشان هنبتدي بس على طول كده. كل الحاجه موجوده different
حضرتك قلت ان احنا where to go from. You have to set a meeting for input for everybody. I'm sure عنده ideas كبير قوي society how it has to work يعني. فنرجو حضرتك to set a meeting او input ممكن نبعت ايميلز في حته ولا حاجه.